Trevor Stratton, and I'm your moderator. I just want to give a little bit of information before we kick it into gear here. Welcome to this 90-minute webinar by CAAN, Communities, Alliances, and Networks. Our title and the focus here is Indigenous Tuberculosis, Lived Experience in Canada. How can Indigenous peoples plan for long-term solutions while experiencing TB outbreaks? So you can ask questions anytime in the chat. So you can type it out anytime, but we'll address the questions after the speakers. We have a 20-minute question and answer period at the end. And also we'll be putting in a couple of links here and there into the chat as we go. We'll provide a link to the evaluation survey near to the end so we can get your feedback so we can do better next time. So without further ado, I want to introduce Albert McLeod. Albert's been doing HIV work in Indigenous country for 4 decades and is a trusted elder, not only in Manitoba region, but all across Canada and in other countries too. Probably a couple of other planets too, Albert. So thank you for joining us. I'm going to turn it over to Albert.
Thank you, Trevor. How's my sound? Is it okay?
Sounds great.
Okay, thank you for joining us today, everybody. I have to use a picture because my camera's not working on my laptop. But I live in Winnipeg, which is Treaty 1 territory, the beginning of the signing of the Western treaties in Canada, and also the homeland of the Métis Nation. I live not far away from where Louis Riel had a plot of land on the Red River. I come from northern Manitoba. My ancestry is Woodland Cree as well as Scottish, who were involved in the Hudson Bay Company fur trade for over 100 years. And I live in Winnipeg, learning from my Ojibwe mentors who teach me about culture, history, tradition, language, and life philosophy of the Ojibwe peoples, which is a great asset in this time of decolonization and reconciliation. And as we're told by our knowledge keepers and our ancestors, that we come to these circles with the gifts and knowledge of our ancestors to do this work on behalf of our community, to improve the wellness of our community members, particularly around TB today. And before we do that, we have to honor and thank the natural world, the spiritual world that we rely on for our existence. So we are told to honor the wind that brings the change of the seasons, and that we adapt to those seasons in the Northern Hemisphere. And when we adapt to the realities of the seasons and the winds, we learn how to survive and we learn how to live. And so we turn to the east doorway and we open that doorway to invite those spirits to join us this afternoon. We turn to the south doorway, we open that doorway and invite the spirits to join us, to listen to us, to guide us if they can. We turn to the west doorway and open that doorway and invite the winds to guide us. We turn to the north doorway and open that doorway and invite the winds to guide us. We know the north wind is very powerful, especially in the winter time when it can be minus 50 degrees below zero. And we have to learn how to adapt to that reality and survive. So wintertime is a time of reflection, of storytelling, inward thinking, and retrospective as we prepare for the spring, which is upon us now. And the geese are coming back and the ducks from the south. And we'll begin that cycle of spring and summer when we begin to collect the medicines off the land and hunt and fish. We also are told to look to the earth below and acknowledge the water, the plants, and the animals that give us life. We turn our eyes to the sky world and acknowledge the plants, the planets, the stars, the moon, and the sun that are representation of the other part of the physical world is the sky world, the spiritual world. And we know in the future we will be in the spiritual realm after our physical life is over. And finally, we weave in the circle of humanity into all of creation as I have described it, that we are part of creation, we are not above creation. We're only a small part of it, and we have to understand to be humble and respectful of creation and learn the power of creation, just as we learned about HIV pandemic, the TB epidemics and pandemics around the world as well as with the recent pandemic of COVID-19. So welcome you all to this circle today to share our knowledge with each other so that we can move forward in a good way. Miigwech.
You make which, Albert. I really appreciate that. It's good to have that spiritual grounding and reminding us why we come here, and also, you know, that our ancestors are with us in this as we respond to some of the issues that are happening in our community, to own our issues in our community, and to take, you know, to lead our responses to the issues happening in our communities. I'm Trevor Stratton. I'm the Indigenous Leadership Policy Manager at CAAN. CAAN is the Communities, Alliances and Networks. Of course, they used to be called the Canadian Aboriginal AIDS Network, but expanded their mandate. I used to coordinate the International Indigenous Working Group on HIV and AIDS for 11 years. So we have that, CAAN has that grounding in international work as well. I'm a citizen of the Mississaugas of the Credit First Nation. I'm here in my traditional territory now. We are Ojibwe people, or Anishinaabe people. And we share this territory through a treaty called the Dish with One Spoon Treaty with the Six Nations Confederacy, the Six Nations of the Grand River, also called the Haudenosaunee Confederacy. And of course, there's lots of other Anishinaabe as well, not just Mississauga that are part of the treaty, but we also have lots of Métis, Inuit. We also honor, you know, the indigenous nations that were here before us, like the Wendat and the Neutral Indians, and etc. A lot of people have crossed paths on this land. It was a very important, Toronto was a very important place where people would meet, and it was a portaging place as well. That's my introduction, and maybe you could, if you want, if you feel safe to do it, just enter your name and what you do. Maybe you're Indigenous, anything you want to say about yourself, and introduce yourselves in the chat so everyone can see who's here. So CAAN was incorporated in 1997 as the Canadian Aboriginal AIDS Network, and has 2.5 decades of history as an incorporated not-for-profit organization whose mandate has evolved from a primary HIV and AIDS focus to include sexually transmitted bloodborne infections, hepatitis C, tuberculosis, harm reduction, mental health, and aging. So CAAN's gone through quite the transformation to become communities, alliances, and networks. Also, you know, we have been working with, or I have been working with, the Global Indigenous Stop TB Initiative, and the acronym is GISI, or GISI, they're affectionately referred to. GISI reached out to me at CAAN for a partnership. The good people at GISI, they've been looking for an Indigenous-led group to take on the responsibility of stewarding the community response to TB, both domestically here in Canada, but also internationally. CAAN has a background in community mobilization, community-based research, and activism in HIV internationally through its work with the International Indigenous Working Group on HIV and AIDS. We call it IGWA. The CAAN also helped to incorporate a new international organization named, it's an NGO, it's named the International Indigenous HIV and AIDS Community. And if Skylar, if you could put the link into the chat, that would be great. If you like poking around in the website there. We call it IHAC, IIHAC, the International Indigenous HIV and AIDS Community. CAAN worked with the International Labour Organization and IHAC, the new NGO, to implement an income generation project in Uganda and Nepal, right in the middle of the COVID-19 epidemic. And we're going to show you some pictures there from Uganda. So using Indigenous traditional knowledge, a group of Indigenous people in Uganda are growing, harvesting, processing, and packaging traditional herbal medicines or remedies and medicines for common ailments. Many people there don't have easy access to clinics and medical facilities and rely on traditional medicine. And in many cases, it's all the medicine they have access to. They don't have access to other types of Western types of medicine. So we also worked in Nepal, in Asia, with groups of LGBTI Indigenous people who are knitting and sewing traditional clothes to sell at the markets around the Kathmandu Valley and at least one other city in Nepal. The background of IGWA, it demonstrates that CAAN does have the knowledge and experience that we require to steward an international movement like the Global Indigenous Stop TB Initiative that's hosted by the Union, the Global Union on Lung Health, by the way. As CAAN works closely with EHAC, the new NGO, there will come a time likely when EHAC is ready to take over from CAAN to be the secretariat for GISI. Mind you, this is all just talk right now. We're having these talks back and forth, but it really looks like CAAN is ready to do this and that GISI is ready to come together and have a partnership together. But you know, CAAN hasn't had dedicated funding for tuberculosis. We had, you know, we've got funding for the sexually transmitted bloodborne infections and some for hepatitis C and HIV, but nothing specifically earmarked for TB, even though it's in our mandate. So I've been trying for the last few years to try to build up the TB file at CAAN. So I joined the Stop TB Partnership Steering Committee, Stop TB Canada Steering Committee, pardon me. And it's been a very steep learning curve, but you know, our CAAN successes are starting to pile up. I have 32 years of experience living with the HIV inside my body, but I've never had TB. So this is about, you know, nothing about us without us. So we hope that in the future we will be gathering people with lived experience and to help us respond to TB in the communities. But CAAN's been doing quite a bit of work over the last few years. It's kind of spotty. It's not a big program, but we have done some TB work. Like back in 2017, 5 years ago, we helped to, you know, the International Working Group helped to edit the Stop TB Partnership's populations briefs for Indigenous peoples, and that's out of the UN in Geneva. CAAN and EHAC co-presented, and that's the new NGO, on a satellite panel at the 10th International AIDS Society Conference in Mexico City. It was titled Achieving the 90-90-90 and Getting to Zero in the Americas Requires Addressing Equity for Indigenous Communities. While we were there, during the opening ceremony, we stormed the stage, unrolled a giant banner, and read out our list of demands to the world. And we made the front page of several newspapers in Mexico City the next morning. CAAN worked with the ILO, the International Labour Organization, another UN agency, in 2019 to implement a qualitative study on stigma and discrimination experienced by Indigenous peoples living with HIV or having TB at work. And if you go to the EHAC website, you can find these reports under, if you click on resources, there's a bunch of great stuff there. I'm not going to tell you everything that we did, but another piece was EHAC, our NGO, the new NGO, issued an Indigenous Peoples Global Call to Action for TB in 2020. And finally, we received a small amount of funding to implement a project called Indigenous HIV and TB Syndemics, Storytelling and Calls to Action. It's a podcast series of 6 different podcasts that we will be developing over the next year. So keep your eyes open for that. And I think I've talked enough. I think it's time to move to our panel now. So I want to introduce to you a brilliant student from U of T, from the Community Research Partnerships and Ethics at Trinity College. Ashley Hilton has joined us, and she's writing a background research paper, very interesting paper on Indigenous TB and Indigenous peoples, and especially on the angle around settler humanitarianism. So I want to hand it over to Ashley now. Ashley, thank you so much for your brilliant work, and please go ahead and introduce yourself and talk it to us and see what you have.
Yeah, thank you, Trevor, and thank you everyone for being here today. I'm just like going through reading all of your little introductions and where you're from, and it's just amazing to see how people are coming here from literally all over the world. So it's very exciting. My name is Ashley. I am currently a 4th-year student at the University of Toronto, like Trevor said. I'm a settler and an uninvited guest upon the land and territory of the Huron-Wendat and Petun First Nations, the Seneca, and the Mississaugas of the Credit River. I am grateful for the opportunities that this land has provided me to learn from, with, and on it. This year, I have been given the incredible opportunity and privilege to work alongside CAAN through the Community Research Partnership in Ethics, housed at Trinity College's Ethics, Society and Law Department. And throughout this partnership, I have been producing a research project surrounding the historic and ongoing impacts of TB on Indigenous communities, with a focus on settler humanitarian interventions. I would just quickly like to send out an incredibly big thank you to CAAN and all the support that they have given me alongside my supervisor, Professor Benoit. It really could not have been possible without all of your support. Before my presentation, I would like to provide a quick trigger warning, as I will be discussing some very big and difficult topics of genocide, death, and trauma experienced within residential schools and sanatoria. So please feel free to leave and rejoin after my presentation at about 2 p.m. Eastern if you do not wish to be here for that, and that is totally understandable and respectable. Today, I will be providing some background context for our discussion on TB in Indigenous populations and lived experiences. I will start off with some basic information about tuberculosis at large, providing a bit of an epidemiological background. I will then provide information on Indigenous peoples' history with TB through early interactions with settlers, residential schools, and sanatoria. I would also like to recognize that these are not my histories, as I am a settler here, and that TB has impacted numerous aspects of life that I will not be able to cover here. For the sake of time and clarity, I have focused on two main settler interventions, being residential schools and sanatoria, to demonstrate only a small portion of the history of TB within Indigenous communities. Tuberculosis, or TB, is a bacterial infection that primarily impacts the respiratory system. However, it can impact the body at large. TB is a highly preventable and curable disease, yet it's the world's most infectious killer, causing the death of 1.5 million people annually. TB takes place in two forms, that of latent TB infection, or LTBI, and TB disease. LTBI is when TB bacteria is present within the body, however, the person does not get sick or develop symptoms of TB, as their immune system is able to prevent bacteria from growing and subsequently causing the symptoms. Furthermore, LTBI is not infectious to other people, yet 5 to 10% of people with LTBI will eventually develop TB disease if they do not seek treatment. TB disease is the less common, yet potentially fatal infection of the TB bacteria. In this case, the immune system is not able to prevent the TB bacteria from growing and spreading, and then symptoms of TB such as coughing, chest pain, weakness, fever, and chills, among others, become present. TB is highly treatable with a course of 6 to 12 months of antibiotics. However, ending the treatment before scheduled can lead to drug resistance and further the spread of a less treatable TB. In addition to the weakened immune system, which favors the development of TB disease, poor living conditions, including overcrowding, can also increase transmission and co-infection. Tina will be touching on this more within her presentation with a bit of more information on the social determinants of health, so I'm not going to go into that too much here. In 2016, Indigenous populations in Canada made up around 19% of all TB cases, while only accounting for 4% of the national population. Inuit have TB rates over 300 times higher than non-Indigenous Canadians, and TB rates amongst First Nations people living on reserve are more than 40 times higher than non-Indigenous Canadians. Additionally, Métis peoples have rates 3.5 times higher than non-Indigenous Canadians. So every group of Indigenous peoples face some sort of disproportionate rates of tuberculosis within their communities. Although Indigenous peoples face a disproportionately high rate of TB, this was not always the case. TB must be understood as a settler disease, as it was introduced to Indigenous four-legged presenter. Yes, sorry, my cat joins me for every Zoom meeting. So although it was introduced during colonization and was not present within Turtle Island before colonization and settlers came over, so as a result, some Indigenous communities encountered TB in the 17th century and have been dealing with it since, whereas others have had more recent interaction with TB in the 19th century and onwards. As a settler disease, interaction with healthcare and contracting TB are often reflected within settler colonialism's control over Indigenous lives. Residential schools are widely and rightfully seen as an assimilationist intervention that sought the cultural genocide of Indigenous children through the direct removal of children from their families and cultures. However, they also greatly attributed to the contraction of TB and death from TB, alongside limiting important cultural knowledge and access of Indigenous medicines that can be used to treat and manage TB symptoms, illustrating that they were not simply a cultural genocide, but a genocide seeking the purposeful death of Indigenous peoples. In 1907, the Canadian government became aware of the conditions in residential schools through the Bryce Report and their impact on the transmission of infectious diseases like TB, in which the average death rate from TB in residential schools was around 25% of all students attending, with some schools facing rates of up to 70% of their students. The immensely poor living conditions within residential schools were attributed to the TB cases as overcrowding, unsanitary conditions, and malnutrition were increasing infection rates and deaths. With the recent recovery of unmarked graves and increasing death toll to over 4,000 Indigenous children, we must all recognize that these deaths are not something to be seen as inevitable, or that authority figures in residential schools were constantly providing medical care for these children, but rather they should be understood as a direct result of the residential school system's intentions at large. The poor conditions directly resulted in the death of Indigenous children. There were a lack of nurses and inadequate medical facilities within the schools, and treatment of TB, if a child were to come down with it, was not widely possible within the residential schools themselves. Amongst this illness and deaths, there are many instances of resistance to the conditions and the residential school system at large, in which Indigenous children would seek to work within the kitchens to gain separate access to additional food to help address their own malnutrition alongside their community's malnutrition within the schools, to help decrease the risk of fatality, as malnutrition greatly increases the risk of fatality with TB, alongside other stories of children running away from residential schools and also caring for each other when they did become ill. In addition to these harms that residential schools created, there were also harms in the loss of traditional Indigenous medicines. Settler treatment for TB within the early 20th century was often ineffective. However, Indigenous methods for treating and managing TB, such as Devil's Club, Ulichan grease, and alderbark, had been proven successful in some cases. Indigenous healing often sought white treatment for white diseases, being settler biomedical treatment for diseases introduced by settlers. However, TB treatments by settlers at this time were greatly ineffective, less available, and less relevant for Indigenous peoples. Indigenous people saw the benefits of their own medicines and healers, even though TB was understood as a white disease. Through the cultural genocide that took place during residential schools, Indigenous children were not able to access the medicine or Indigenous healers to help address TB when it arose. Indian hospitals and sanatoria were instituted in the late 18th century and greatly expanded upon in the post-World War II era to address the perceived threat of TB spreading from Indigenous peoples to non-Indigenous peoples. Their creation by no means was to ensure the health and well-being of Indigenous peoples with TB or Indigenous peoples generally, but rather to ensure that settler populations would not be impacted by the health of Indigenous communities and peoples. Patients were admitted into the hospital based upon them holding an Indian status, perpetuating a medical apartheid system in which Indigenous peoples received drastically poorer and separate medical care, as Indigenous-focused sanatoria and Indian hospitals would only receive 50% of the funding per capita that a white hospital would receive. Indigenous peoples also faced longer times within the hospitals as they were perceived as less trustworthy in maintaining their medical schedule. Through this longer time in hospitals, Indigenous peoples faced chronic maltreatment and abuse from the staff in various ways. Medical experimentation would often be conducted on Indigenous patients who were wrongly assumed to have TB, and surgeries would be conducted with no valid reason, simply just for medical experimentation. Alongside the medical experimentation and lack of funding, the staffing within sanatoria and Indian hospitals was drastically different from that of white hospitals, in which the staff would often be unlicensed, untrained, and frequently understaffed, leading to just a generally lower level of care provided. Similar to residential schools, sanatoria sought to separate Indigenous peoples from their families as another means of assimilation. Inuit were often sent to Southern Ontario to receive treatment. Oftentimes, they may not survive the trip to Southern Ontario, or they would potentially pass while in a sanatorium. Yet their families would not always be notified of their passing, resulting in a further removal of Indigenous peoples from their communities and culture, often permanently. This, alongside the longer times that Indigenous peoples faced in hospitals, greatly increases the separation that was purposeful by the government. Within sanatoria and Indian hospitals, Indigenous people were not able to speak their native language and communicate with their healthcare providers. They and their lives were regarded sort of as a living dead, left to die by the government's lack of adequate funding and care, at a bare life in which their pure biological life was prioritized over the means in which the life they lived. The Canadian government did not see Indigenous peoples as worthy of life or their life as being worthy in and of itself. Assimilation and loss of Indian status would have made Indigenous peoples more worthy, as they would not have been patients at Indian hospitals and would have been more patients at white hospitals. However, racist and subpar medical treatment still prevailed and does to this day for Indigenous peoples within the biomedical system. The history of both TB treatment and contracting TB has been greatly influenced by the Canadian government's control over Indigenous life. As a result, our movements forward with addressing the disproportionate rates of TB in Indigenous communities must seek to prevent the replication of those harms and new harms, and seek culturally safe and relevant care that holds government authorities responsible for their commitment to address TB and address it within Indigenous communities in a proper and safe way. That is all I have. Thank you all so much.
Wow, that was really great. That's some serious research there. You know, actually, a lot of people in Canada, a lot of Canadians were shocked when the discovery of so many unmarked graves, and even conservatives who always said, no, it's not happening. They felt like they were lied to, or that the truth was hidden from them. People that I know that are conservative, they're like, they believe it now. But we've been telling them this story for a long, long time, and the information is there. You proved it. You went out and researched and found all this information and did a presentation to us, giving us not only the background of TB and how it works, but also how through colonization, TB became a major problem for Indigenous people. So I really very much appreciate your work, and I look forward to seeing you present your research paper in the next few days. I think it's coming up very soon. So I'll see you there very soon. Thank you so much for that. Amazing. This is really great work. I'd like to turn our attention now to Ida. Ida, I'm not sure how to pronounce your last name. I think it's Lemay. And Lemay. Okay. Thanks for the pronunciation correction. And you're an alderwoman from La Loche, a community in Saskatchewan. And I've been really enriched by getting to know you as we've been preparing for this TB webinar. And thank you to Anne Fanning, who I guess you've known for so long, who is basically the chairperson of the Global Indigenous Stop TB Initiative, GISI. So thank you for bringing us together, Anne. And I'm going to turn it over to you, Ida, for introduce yourself and let us know how things are going in your community and with you. So go ahead.
Merci. Hello, Merci, everyone. I'm honored to be here to talk to you about tuberculosis and how it has affected me and my community. First of all, I'd like to introduce myself. My name is Ida Lemay. I'm a Denisumene. I have lived in La Loche, Saskatchewan all my life. Other than receiving the education that I have, I'm currently a retired school teacher. I've taught my Denisumene language to my community, my high school students. I'm very honored to be here. My present role in the community is an alderwoman, so I speak for the community, with the community. So we're side by side, together, we do this together. So again, I'm honored to be here. I'll talk a little bit of the history of TB, how it has impacted me personally. I come from a family of 9. My mom and dad raised me with very good lifelong learning. Number 1, being respectful. Number 1, that was the most important thing that we learned from our parents, is respect the surroundings, the land, the people that are around you. So throughout my life, I carry that with me. My mom, when my 2 brothers were born, my oldest sister, my oldest brother were born before I was born. So like I said, I come from a family of 9, and I'm in the middle. When my 2 oldest siblings were born, my mom had tuberculosis. So my mom had to be removed from the community. This is stories that I have heard from my parents. This is not something that's documented. Like, we're all oral listeners. We're all teach oral history. Not so much of our history is documented. When my 2 siblings were born, my dad been out on the trap line. My mom was placed in a sanatorium in Fort Campbell and Saskatoon. Those were the 2 sanatoriums that she was at. One of Dad's stories was that while my mom was there, my mom was in sanatorium for numbers of years. I'm not just saying 1 year. It's a lengthy period of time. When my dad came back from the trap line and sold his traps to the Hudson's Bay, there was no road leading out of the community then. So he went to the nearest community, which is Buffalo Narrows, and with a dog team, and hired a taxi to go to Fort Campbell, Saskatchewan, which is way on the other end of the province. My dad said he spent overnight visiting Mom and had to return the next day. Mom's stories were very, as she told the stories, it's very sad when you are in a room. During my years of education at the University of Saskatchewan and University of Regina, my mom often stayed with me. So one day we went to visit, well, lots of times we spent to visit my uncle in Saskatoon. So the one day we were in Saskatoon, my mom asked if we could go to see if the sanatorium is still there. And we did go there. The building is no longer there now, but it was there. So we went in, and my mom showed us the room that she stayed in for more than a year. It was much like a cell. It was a small little room, very difficult to see. But I kept myself together, and so all of this has really affected Mom. Like, when Mom returned, and after that she had seven more, addition to the family. The TB sanatoriums are something that when I went to visit, to go see that area again in Saskatoon this summer, that land is cleared out now. I got out of the vehicle. The energy of that area was very different. I couldn't stay around the area for long due to the energy I was receiving. I'm going to go talk about my family. I have three children. The oldest, Lori, 43. My second, Chad, 26. And my youngest, Gina, who's 22. My oldest, Lori, about 14 years ago, became very sick before Christmas. He said he was having very bad headaches. He was throwing up. He'd go to the doctor. The doctor said that he drank too much. He wasn't admitted at that time, but just treated with Tylenol, etc., for his headache. Right before New Year, Lori was admitted into the hospital here in town, and I went to go see him. And the way he was responding was, it was not normal. He was kind of staggering. He was answering questions wrong. And the doctor pulled me aside and said there is something wrong with the brain. So they medevaced him to Fort McMurray, Alberta, which is the nearest hospital, and a 10-minute flight from here. And from there, treatment was transferred to Edmonton. And Lori had a lengthy stay at the hospital. Lengthy meaning from December on to like June. So at least 7 months, 8 months into the hospital. And I was along him throughout 3/4 of the way until he was transferred back to Saskatoon for physiotherapy. During his time in Alberta, Lori received like he had to get a shunt. Lori's before TB had got affected my son. Lori was very active. He played hockey. He'd go hunting. He'd do many. Sorry, give a moment. He'd do many things out on the land. Today, my son a month ago, he had another surgery, and they had to put a shunt in his spine. And this is all as a result of TB, which is a very preventable disease. You know, as we talk about it, it's so nice to hear from the researcher. I forgot her name. Emotions came to me again when we talk about how TB is so, with residential schools and sanatorium, how they are really connected, and how we are being experimented on. And I feel today we are still on that experimentation. Why? Because we have resources, we have the tools, but yet today we are still losing community members because of tuberculosis. Just recently, over a month, we lost a young community member with 5 siblings. A young person losing a mother, gone, with 5 siblings left there. and how long it has to take for treatment to start when somebody is diagnosed with tuberculosis. When a person is treated, it doesn't take. Then when I have an infection of some sort, I go see the doctor. I get a prescription. I go to the drugstore. I get my prescription. I can start that same day. Tuberculosis is treated differently. I don't know how other communities do it, but here in our community, when you're diagnosed with tuberculosis, there's a waiting period, sometimes 2-3 weeks before you even start your medication. Meanwhile, that bug is still growing and you're contacting others. There needs to be a more preventative stuff here. Another thing that we also have to remember is because TB in institutions, when I say institutions, I'm talking about the institutions that are not very helpful. I'm saying, like, for example, in our jail systems, when people are incarcerated, I feel like sometimes it's like a sanatoriums or residential schools because, you know, like you're in confined. There needs to be more people on the ground, like our TB doctors don't come here regularly. I don't know when I asked a question as an older woman at a table, one was how often the TB specialist comes to our community. During COVID, there was no one coming here. So that's over 2 years. But people don't they do follow-ups? Don't they do blood work, etc.? Personal experience. I know that some of my close family members, you know, people that I know, like, do you ever get to see the TB doctor? No. When's the last time you get a blood work? Oh no, not even. Your liver has been, you know, you have to monitor that. And those that's why I'm saying we're still been experimenting on. That's exactly what I mean. You know, people put on TB meds, the TB nurse assistant deliver the meds, make sure the person takes it, and off they go. And then come back again the next day. Where's the education behind it? We need to be more proactive in the schools, where the young people need to understand what tuberculosis is about and how it's affecting us. Right now, presently in the far north, we have TB outbreaks. Why is this happening today, in today's, when we have the tools in front of us? Right now I'm talking to you, where I don't know where you're sitting, and some of you sitting someplace. The technology that we have, we can use it. We can't just always be collecting data and saying that, but there must be a prevention. How do we move forward with this? You know, planning for long term. I'd say in my community, I'm going to speak for many of our brothers and sisters across Turtle Island, that we need more, you know, doctors, frontline workers to assist us in battling this disease that's been with us for a century. You know, like researchers said, it's the white man's disease. Totally in agreement. So let's work together and battle it. You know, like, we have to do something. We can't just be, right now it's very important. It's important right here we're sitting. We're going to be turning our page and saying, this is what we need to do. But if we just sit here and listen to our stories and document it, but we need action. And forget the boundaries. Tuberculosis has no boundaries as any other disease. You know, like we have policies in place at the provincial level and at the federal level. We have a community here that has First Nation, and then right next door is a Métis community. But then there's that policy, the mandate that, you know, like they have their own agenda and they have their own, like we don't, but yet we're still trying to achieve the common goal is getting rid of, you know, diminishing that disease. So all of that stuff has to, the barriers, you know. I'm kind of got emotional, and I was hoping that wouldn't happen, but I'll be okay. I'm all over the place because I didn't start off on the right foot here, but
you covered so much ground. You're doing really well.
You know, like I said, for planning for the future is, you know, we need to sit together and forget about the boundaries, you know, like the NISA or the, you know, Saskatchewan Health, or, you know, we need to work together about how can we do this. Language is important. When we are talking to high school students, we can use the language we're using today, but if you're talking to the community, the language has to be different. And we always have to be respectful of our Indigenous language. You know, like doing it in our language, like like right now here I'm speaking to you. If I was to do this in my language, it would be very powerful. But I have to think and say in Dana in English, think in Dana, I'm moving at a pace so fast. So I'm speaking for those that are unable to say, because when we say the word tuberculosis, a lot of people would turn away and not be part of that, would not be part of that discussion because of the attachment, the stigma attached to it. We need to get rid of that, and that's the way to do it is through education. You know, through when people are educated more, there's prevention happening. You know, like if the more I'm aware of a content, the more I prepare myself. Those are the things that we have to remember. So how TB is delivered in my community is maybe that needs to be altered a bit. I don't really know the procedure, but based on the experience that I have seen, there needs to be a better approach than what we're practicing, because sometimes the older model isn't working and we need to change it. And sometimes the older model works, and we need to continue using it. It's okay. But if it isn't working, there's something wrong with the picture here. And if our stats numbers are very high, when we have the TB meds, something's not right. So I'm advocating for more medical assistance here at the community level, and I will continue to be that voice, whether I am not connected with anything, but as a single mother trying to achieve a healthy community and taking a proactive approach with the help of the resources I have in front of me. So thank you for listening to my story. I know sometimes it gets very difficult, but I did manage to go through some of the stuff that important, and like I said, we just need to grab the reins and take some action, because I don't know how many TB doctors we have in Saskatchewan. Maybe a handful, I don't know. I can't answer that, but we need to have more of them. And sometimes, family doctors aren't, like I said, my son, when he was getting that first contact with TB, when he got the TB meningitis, like the family doctor, whoever the family doctor was, maybe wasn't quite aware of the symptoms of tuberculosis. Maybe that's something that we need to put into the training, portfolio of physicians. I don't know, but that's, like all doctors we had, they I know, like we would get TB tested if we were there, but today we don't get TB tested unless maybe you had contact. Or
Yeah.
Oh, there's another part there I wanted to share, which was important because about TB testing. When I was growing up as a child going to school, there used to be this big semi come pulling into town, and they take x-rays and blood work of every child that went to school. And that was how TB was, like identified and how it was treated. There were, I'm not saying go back to that, but obviously something worked, that TB was, reduced, the numbers went down, but there has to be an approach not similar to that, but a way where we can start testing and start making it open.
That's a
COVID
really
has
good way
really
to,
changed our, pardon?
I was just going to say that's a really nice way to close, because Tina Campbell is going to be speaking next about trying to help coordinate all of the workers on different First Nations and that.
Right,
so
on.
a great way to
Yeah,
sort of,
like First Nations does their, but in the community, like municipalities, they're connected with the province. They have their own mandate.
the jurisdictions need to start talking to each other.
Jurisdictions again, see, like First Nations can be doing very amazing work here, amazing work, but yet at the provincial, like public health, it's different again. That's really irritates me. Need to connect. Yeah. Well, I'm going to close off since we have somebody else waiting. I don't want to keep but I thank you for giving me this time to express my experience, and moving forward, we will plan for more.
Oh yes, this is just the first. This is just the first TB webinar. Thank you so much.
All right, thank you. And Trevor, I'm going to try and put it on mute, because put it on mute. Okay.
And I just wanted to say I lit a smudge because it was really heavy there, and I thought I'd light a smudge for you and for everybody else, all the TB survivors and all of us here. So thank you so much for honoring us with that story. It's very sacred to me, and I'm sure to others. There's so many comments supporting you in the chat, so read them over. You'll see there's a great amount of support there. So we have Tina lined up to talk to us. And Tina, of course, is a registered nurse and TB advisor for Northern Intertribal Health Authority. I'm just going to hand it right over to you, Tina. You go right ahead.
Hello, everyone. Thanks for joining today. It's a pleasure to be here. I just wanted to say thank you, Trevor, for the introduction, Elder Albert for the opening, Ashley for her presentation, and Ida for sharing her personal history and experience. It is so important that people tell their story and the lasting effects the history continues to have on our people. It was a very powerful message, so thank you very much for that. I also had family that attended sanatoriums in Fort Capel, and it is never easy to talk about nor to hear about, so I really appreciate you sharing your experience. So my name is Tina Campbell. I'm a registered nurse. I'm TB advisor at Northern Intertribal Health Authority in Prince Albert. I have about 11 plus years of experience within the TB field, and my experience spans over Nunavut and Northern Saskatchewan. So today I'll be providing a presentation on tuberculosis and Indigenous communities. And to begin, I'd like to acknowledge that I am talking to you today from Treaty 6, the traditional territory of the Cree and the homeland of the Métis people. This is where I am privileged to reside and work. Next slide. So just a brief outline, TB in Saskatchewan, I'll talk about social determinants, some challenges and successes, and how to move forward with care. Next slide. So just some facts, how common is tuberculosis? The World Health Organization estimates about 23% of the world's population is infected with TB. Canada has one of the lowest rates of active TB in the world. There were 1,796 cases of active TB reported to the Public Health Agency of Canada in 2017. There is an incidence of 4.9 cases per 100,000 nationally. So despite these low overall numbers, Indigenous and foreign-born Canadians continue to be disproportionately represented among TB diagnoses. Next slide. So what is TB? TB is a disease caused by the Mycobacterium tuberculosis bacillus. TB usually affects the lungs, but can also affect other parts of the body like your bones, joints, kidneys, the brain, and reproductive organs. TB can be spread through the air when someone with active pulmonary TB coughs, sneezes, or sings. Next slide. So these TB droplets are expelled when somebody coughs and can remain in the air for hours. Next slide. Some signs and symptoms of active TB: coughing up sputum, a cough that lasts longer than 2 weeks, coughing up blood, night sweats, fever, unintentional weight loss, loss of appetite, some symptoms of extrapulmonary TB, so TB that's not found in the lungs, may mimic other illnesses, and it can be hard to diagnose or assess. So we have to stress the importance that healthcare professionals are given an orientation informing them of the incidence of TB in the communities they provide their services. And more awareness and understanding can lead to earlier diagnosis and therefore preventing serious forms of TB and also TB transmission. Next slide. So some risk factors: recent or ongoing contact or exposure to somebody who has active TB. Your risk of developing active TB increases when you have co-infection with HIV, you have other health conditions such as chronic renal failure, cancer, diabetes, or if you experience poor nutrition, cigarette smoking, children under the age of 5. Next slide. Or if you are Canadian-born Indigenous living in areas where there is increased TB activity. For most people in Canada, the risk of developing active TB is very low. However, the rates of active TB are higher among Indigenous peoples. So why? Indigenous and isolated communities face many social inequities. As reported by Statistics Canada, 37% of First Nations living on reserve reported living in crowded households, compared to 8% of the non-Indigenous population of Canada. The ongoing housing crisis and housing conditions, such as poor ventilation and air quality in the home, can increase the spread of illness. Food insecurity, which is the state of being without reliable access to sufficient quantity of affordable, nutritious food, can lead to hunger and malnutrition. The high prices of food in our isolated communities in northern areas of provinces and across the Arctic. Fly-in communities have increased pricing due to the cost to fly up the food. This forces families to choose processed foods over fresh fruits and vegetables. Processed and canned foods last much longer, and sometimes vegetables can spoil quickly due to freezing on their way to the community. Stigma. TB is heavily stigmatized. Some people think TB is a disease of people in poverty, substance users, or people who have HIV. Stigma is also present in First Nations communities due to the historical events in relation to TB. Negative experiences may form views of TB within a family unit, and this view is passed down from generation to generation. Access to health care. First Nations clients can experience delays in diagnosis of active TB disease when they are great distances from medical facilities or hospitals. I have experienced delays in transport of lab specimens to hospitals from remote communities, sometimes spoiling the samples, which forces the healthcare staff to have to recollect, and this may produce loss of trust in the already strained relationship between the Indigenous population and healthcare practitioners. Also, the high turnover of nurses from southern parts of Canada may not know how to provide TB care, and an opportunity to screen could be missed or delayed. So Ashley talked about some statistics globally, so let's quickly look at the comparison of rates in Canada. So Canada has an overall low incidence rate, as I mentioned, however, higher risk for TB among Indigenous populations. The rate of TB among First Nations living on reserve is over 40 times higher than the Canadian-born non-Indigenous population. And the risk of TB in Inuit Nunangat, which is the homeland of the Inuit, which is spread across the Canadian Arctic, is almost 400 times higher than the rest of Canada. And I also want to mention here that the national data is over 5 years old, so we need to have updated data in order to make some changes. The next slide will show you a closer picture of Saskatchewan. So in Saskatchewan, as of 2021, the TB rate is about 9 per 100,000 population. It was a 30% increase in TB rates in Saskatchewan First Nation on reserve from 2011 to 2021. And it's 6 times higher than the Saskatchewan rate in 2021. Overall, 100% increase in TB rates in NITHA jurisdiction from 2011 to 2021. So you can see that NITHA is the blue and it's much higher than the rest of the province. So active TB cases specifically in the NITHA jurisdiction. So TB is a public health crisis in some First Nations, Inuit, and Métis communities. Previous studies have linked it to living conditions, health inequities, historical traumas, and stigma. They help sustain high incidence rates of active TB in some Indigenous communities. So for the past 10 years, NITHA has recorded the highest active TB case rate in 2021, causing an outbreak declaration in some communities. And 20 communities have reported at least one TB case from 2012 to 2021. Next slide. So Northern Intertribal Health Authority is where I work. It's a First Nations partnership organization comprised of Prince Albert Grand Council, Meadow Lake Tribal Council, Peter Ballantyne Cree Nation, and Lac La Ronge Indian Band. So together, these 4 partners provide and maintain health services in 33 First Nations communities in Northern Saskatchewan. Next slide. The NITHA TB program provides support to our partner communities by working quickly to identify, screen, and refer for preventative treatment, educating communities about TB and its symptoms, the factors that increase the risk of developing active TB disease, and the importance of seeing a healthcare provider early. Supporting TB program workers and community health nurses to administer direct observed therapy and support TB programming. And working in partnership with Saskatchewan TB Prevention and Control and other stakeholders to develop and implement effective strategies to work towards TB elimination. So not all communities are affected equally by TB. Some have very high rates of disease, while others have very little. Much of our time and effort is dedicated at those high incidence communities. So in Saskatchewan, our TB program is run by the province. Nurse clinicians and physicians are centralized in Saskatoon. Our TB nurses here at NITHA try to bridge the gap between clinicians and community TB workers and TB programming. So Ida is absolutely correct that the delivery has to be tailored and changed we need to hear from community members like herself and their opinions to try and make these changes happen. And in my role at NEITH, I really hope that we can move towards that as well. Next slide. Oh, you're already at the next slide. NEITH TB program, so our high incidence strategy. So identification of a high incidence community has to have 2 or more cases in that current year. A 5-year average of at least 1 case in the previous 3 years, and 5-year average incidence rate. Implementation of our high incidence strategy. We have outbreak teams, directing resources to areas of need, and increased community engagement and awareness campaigns. Next slide. So our high incidence strategy includes 7 main components: community engagement, enhanced case finding, enhanced contact tracing and investigation, use of targeted screening, enhanced general awareness and education, and improved occupational health, and also health determinants advocacy. Next slide. So we had an outbreak back in 2018, and the outbreak exposed 3 key gaps in outbreak management, which included 2 incidents of delayed diagnosis, challenges in treatment compliance with past and present cases, as well as difficulties in achieving TB awareness among clinic staff and community members. However, the outbreak also revealed successful outbreak management activities. These included outstanding case finding through social network contact investigation. And it was recommended by this outbreak to continue the use of social network analysis for case detection activities. So anytime you have a diagnosis of a smear positive case, which is there's a lot of bacteria, germs present in the sputum that they collect, it is indicative of a delayed diagnosis. So at this point, one is likely had been symptomatic for months. So potential reasons for delayed diagnosis include homelessness, transient between communities, accessing care, but not being assessed for TB, care providers not having TB diagnosis as a differential. Unfortunately, we have seen this, especially during COVID. So people being tested for COVID, found negative, and not screened for TB when in fact they did have TB. It has been noted that there's some lack of urgency or concern or prioritization for TB programming among some clinic staff and community leadership. Also turnover of nurses, like I said, who are not aware of the TB incidences, even in a high incidence community. And then lack of prioritization for support for the TB program workers. So often they'll phone our nurses here at NEITH, and it's really hard to kind of offer some support from hundreds of kilometers away. So our outbreak response approach, the goal is to have early detection, diagnosis, and treatment of TB, additional staff, mobile clinic, and mobile x-rays. Social network data of tuberculosis, patients could explain the source and pattern of disease spread. The findings highlight the potential of social network methods for understanding TB spread in the outbreak communities. So social network analysis can widen the net. Different language used when questioning who you've been around, doing home visits as well, can identify others that may have not been named. Next slide. So our current outbreak, Next slide. Oh, I think I had these mixed up a little bit. Okay. So current TB outbreak we had 2 outbreaks declared in October of 2021. Between 2 communities, there's roughly around 100 people on medication. And you can see there's a breakdown here, community 1 and community 2, active versus latent cases. There's over 400 clients identified as contacts. And then we had to hire more TB workers in the community to assist with this workload. Next slide. So a rise in pediatric cases in current outbreaks is a growing concern. So almost half of the diagnosed active TB are children. The need for increased screening of high-risk symptomatic children in communities. Children under the age of 5 are at increased risk of developing life-threatening forms of TB, such as TB meningitis. So often symptoms in children can be nonspecific, fever, reduced playfulness, failure to thrive, and therefore being harder to diagnose. Next slide. So some challenges: the need to encourage community health nurses to take lead and supervise TB program worker roles and provide consistent support in the community. Some TB workers do not have workstations in health centers. This can be discouraging. And TB nurse visits are also affected by lack of space and lack of accommodation in communities. So they want all this support, but to accommodate us is not a priority, I guess, as well. Short staffing in communities, high turnover. So consistency needs to be maintained in community to ensure no TB cases go undiagnosed or experience a delay in diagnosis. Leadership and community members are not aware of the state of TB in their communities, despite awareness campaigns and resource development by us here at NITHA. Next slide. So TB care barriers that remain: social determinants of health, so lack of clean drinking water, overcrowded housing, poor ventilation, inadequate nutrition. Mistrust continues with institutions, so developing a trusting relationship is important. Stigma remains and remoteness of these communities, inadequate resources, so nearest hospital in another community or further south. Next slide. So historical TB control practices in Canada have contributed to stigma and discrimination towards those with the disease, as well as fear and mistrust of the healthcare system. These individual and system level factors result in delays in TB diagnosis, ongoing transmission, poor outcomes, and lower treatment completion rates. Next slide. So some successes: TB workers in communities continue to be vital when it comes to DOT. So TB program workers in our communities are community members that are, well known to the community and speak the local language. And I think that is so important. They're the link between clients and the NITHA TB nurses and also TB prevention and control nurse clinicians. So I always, whenever I talk to them or I'm able to visit them in the community, I say that, you're very, very, very important to TB care in our province. And it's helpful for them to see, for clients to see that familiar face consistently, because I know it can be frustrating to see a different healthcare practitioner at every visit. So even with COVID, TB workers were being utilized for other tasks on top of their TB roles, and they kept on working, which was amazing. Our incentive programs continue to contribute to high success rates with DOT and treatment completion in our communities. So I seen Trevor wrote the direct observed therapy. Next slide. Which I'll talk a little bit about here. So the treatment standard in Canada for TB is done by direct observed therapy. It is extremely important to remember how much a TB diagnosis can change your life and lifestyle while you are on treatment. And as Ashley had also mentioned, treatment can last for months. Next slide. So direct observed therapy, or DOT, means a trained healthcare worker or designated individual, excluding a family member, provides prescribed TB drugs and watches the patient swallow every dose. So DOT is the World Health Organization standard for TB treatment, for treatment of TB disease. So why DOT? We cannot predict who will take medications as directed and who will not. People from all social classes, educational backgrounds, ages, genders, and ethnicities can have problems taking medication correctly. Treatment completion success rates are higher. DOT helps patients finish TB therapy as quickly as possible without unnecessary gaps. DOT helps prevent TB from spreading to others, decreases the risk of drug resistance, and decreases the chances of treatment failure or relapse. These long durations of treatment can be difficult for patients to complete, especially once they are well and need to return to work. Failure to complete treatment can lead to relapse and even death in individuals, and also has important public health consequences such as increased TB transmission and development of drug resistance. Next slide. So successes, we've increased our collaboration between TB Prevention and Control and Indigenous Services Canada, case identification through contact investigation efforts. So we were able to find quite a few cases through our contact investigation. Our TB nurse presence and assistance in communities, we've been able to consistently be in these outbreak communities since October, despite having a really small team for 33 communities. So between October 2021 and presently, We have provided over 1,100 hours in the community, and 500 contacts have been identified. We have been using our portable X-ray, which, you know, gives people more access to care, and the use of gene expert testing, which can diagnose cases in a few hours rather than waiting days or weeks, as Ida mentioned. So moving forward, what can you do? We can learn more about TB and TB programming. How can you help? Start the conversation about TB in your communities. Next slide. So I'm almost done here. So we have a responsibility to uphold the Truth and Reconciliation Commission of Canada's call to action. So we call upon all levels of government to increase the number of Aboriginal professionals working in the healthcare field, ensure the retention of Aboriginal healthcare providers in Aboriginal communities, provide cultural competency training for all healthcare professionals. So the benefits of cultural competence in healthcare is improved health outcomes and increased access to care. So cultural competency also incorporates learning the historical TB care with Indigenous populations and understanding how it still affects people today. So next slide, sorry. What can you do in your communities? Addressing attitudes towards TB, making cultural awareness training mandatory for some organizations, addressing attitudes towards TB programming. So healthcare workers have to take on TB programming as a priority, especially in high incidence communities, and understanding the social determinants of health and the effects on TB. Next slide. So Ida is absolutely right. TB is treatable, curable, and preventable, and absolutely no one should be dying from this disease. And I honestly think that our communities deserve a lot better in terms of TB care. And I know we're just ending a pandemic and everyone is, you know, burnt out and exhausted, but we have TB outbreaks in these communities currently. So moving forward, we need to treat them as urgent. And we all have the same goal, which is to end TB in our communities. Next slide. And thank you.
Wow, thank you so much, Tina. That was excellent. You sure know what you're doing. That was very good. So yeah, we're talking about a low prevalence country for TB. TB is not a lot of TB around here, but there's high prevalence communities, Inuit and Métis, and we haven't talked about people who are immigrating here or newcomers to Canada. There's also high rates in that population. So thanks so much for that. I'm thinking of, you know, it's been such a learning curve for me and for CAAN as we're beginning to do this TB work. And I really appreciate the advice we are getting from Dawn Enerson and Anne Fanning from the International Union Against Tuberculosis and Lung Disease, also called the Union. They're the host of GISI, the Global Indigenous Stop TB Initiative, and I've been learning so much from them and also from the Stop TB Canada Steering Committee. So some of the things I learned, you know, for the TB response, there's an urgent need to find the person who has infectious TB, you know, so that they can be treated with medicine quickly and make them non-infectious. Within 2 weeks of starting treatment, that can happen. Then there's the very important work of finding the people who may have gotten TB from that person. They need preventative medicine to give them prevention, you know, before they get sick. This is immediate contact follow-up and prevention treatment. Sometimes you find other cases when you're doing this immediate urgent contact follow-up, and then you enlarge the follow-up in concentric circles, you know, bigger and bigger until no more cases are found. And then you make a plan to survey the entire community with a skin test or IGRA test using a blood sample. And if anyone's positive, they need an X-ray. If there have been cases chronically over years, then, you know, there have been in La Loche, then in other communities, you probably have to do this annually. So let's talk about the principles of TB care that Donald and Anne taught me. It's fairly simple and straightforward, these 4 principles of effective tuberculosis. The first one is political commitment. Without an explicit declaration of commitment, it's very hard to hold authorities to account. This implies that government authorities take responsibility to ensure that the services provided as needed, It means, first of all, that politicians and administrators clearly specify in writing that TB is a problem and identify its level of priority in the health system. It means that they commit to provide the resources, above all human resources, like the people in the community, to carry out the tasks, and that they support and provide written guidelines on what's recommended as best care. It can also be measured by, to the extent to which authorities provide opportunities for community members who will stay to become healthcare aides and nurses and doctors. The second principle is to secure a supply of medications and diagnostics. Continuous care is essential to ensure that the services are in place for the long haul that is required to cut the spread of infection in the community. As treatment is relatively prolonged, it's long, and detection must be carried out wherever and whenever TB is suspected, which can be anywhere and anytime, a secure supply is essential. If the supply of tools for diagnosis are interrupted, highly infectious cases will go undetected and the infection will spread. If treatment is irregular or interrupted, the patient may have they may become chronic with complications and may continue to spread infection to others, and may have the bacteria develop resistance and no longer respond to the treatment. The third principle, scientifically proven, standardized methods of diagnosis and treatment. Some practitioners have traditionally chosen to individualize approaches to providing health services to individual clients. While this may work, of other conditions, it presents a lot of dangers where TB is concerned, right? If the methods used for diagnosis and treatment are not correct, infectious patients may be missed and go on spreading infections throughout the community. Patients may not be cured of their disease and become chronic patients with complications and with potentially drug-resistant bacteria. In general, those who are most infectious and most likely to spread the infection through are those, and these clients must have the highest priority among all those who are presenting for care. Fourth principle, this is the fourth and last one, monitoring through regular recording and report paperwork. It's often viewed as a drudgery and something that professionals would prefer to avoid if possible. This is not true where TB services are concerned. Everyone who's involved in providing health services believes that patients are being given the best care and that the outcomes of care are as good as they can be. In spite of this commitment and belief, errors and mistakes are made more often than one realizes, or the manner in which the care is being given is not appropriate for the clients or the community, and the results are not as good as they should be. This can only be detected by systematic monitoring of the care being given, and that means that the care must be carefully and correctly recorded and routinely reviewed and evaluated to be certain that what one thinks is being provided is actually happening, right? So yeah, I want to stop there. I have more I could share with you, but there's a couple of questions that have come through, and I want to just see if one of the panelists would be able to answer one of these questions here. One of them is that kudos to you and your team on managing these 2 outbreaks. I guess this is to Tina. It's an incredible amount of work and dedication. I'm curious if the use of video DOT is possible in these remote communities. Anything on that? What do you think of that, Tina? Video DOT, is that possible? Tina may have been called away because she's a very busy person there. And there's another question here. Is man-toe testing still happening or funded widely for First Nations communities? I think we may have lost Tina, and I'm not able to answer that, but maybe there's somebody online. I know that Don and Ann are both online, so maybe we could have those answers put into the chat there. Skylar, if you could drop in the link for the evaluation survey so people could have a look at that, and so that we can improve our webinars as we go forward doing this TB work, that'd be much appreciated. If you could please help us make these a lot better and just go through the questionnaire and let us know what you think and make some suggestions on how we can improve this in the future. So I really want to thank all of the speakers. You've been so great. And, you know, we had the background, the historical background, and that whole settler humanitarianism angle and all of the, you know, the long history of TB and Indigenous peoples in Canada. And then we had Ida's rather heartbreaking story of TB in the communities and several outbreaks. And then we heard from Tina from the Health Authority and the central coordination of the TB work that's happening in various First Nations around northern Saskatchewan that belong to the Intertribal Health Authority. So thank you so much. You helped us really pull together the pieces about how are we doing? I mean, how is Canada doing around TB and Indigenous peoples? And it looks like if it was a report card, it might be a failing report card. And we could do a lot better. And I'm hoping that CAAN can be part of that. CAAN is a network. That's what CAAN does best, is bring people together and help communities so that on in the principle of nothing. So with that, I thank everybody, Chi Miigwech, for joining, and I'd like to in Manitoba, Albert, if you could take it from here, we'd be very much appreciated.
Thank you, Trevor, and everyone who participated on today's discussion. And as we know with COVID-19, that we need to be prepared, and there's some similarities in terms of exposure to closed spaces around with TB, and we can see around the world how quickly governments responded to the reality of that airborne transmission. And so we need to understand too that Canada has an obligation to Indigenous people, not only to do research around epidemics and pandemics, but to prevent them and not just document them. That is the purpose of science. The purpose of health research is to prevent. And in Canada, we see for Indigenous people and other places in the world, these pandemics and epidemics of TB continue. And you know, if we're to be an equitable, just society, we have to make sure health is equal for everybody. So we want to thank those spirits who joined us today to guide us in our conversation. You know, to think about those people who are struggling with violence, those people who are struggling with this pandemic, especially now with those people with TB as well. We learned, you know, of those who have tested late and have symptoms of a very preventable infection. So we thank their spirits and send them back to the directions from which they came. And we will learn what they have shared with us in the future. The knowledge, after listening to us, they will have given us insight, ideas, you know, things we can do to resolve this issue. So thank you, everybody, and we'll meet again. There. Hope my mic
Thank you to all
was
the
on.
speakers. Yes, it was totally. Thank you. Thank you very much, Albert. As usual, very well done. And thanks for your very, very strong support for our webinar here. Thanks to everybody. Thanks for joining in. We've been on for 90 minutes, and we will be posting this to the website and to YouTube on CAAN's social media channels. So you'll be able to watch it if you miss parts of it, or if you want some of your friends or colleagues to watch it, maybe your family members. We'll be sending the link to everybody through email for the evaluation as well, and also the link to the recording. So Chi Miigwech, and have a great day and have a great weekend as well. Take care. Bye for now.
Thank you all.